I'm just going to give you a bit of an overview about me as a customer of yours. I think is probably trend of these numbers because they are going up. So 11% increase in A&E as an example is not unheard of in the system. So it's important that we are able to automate the pathway, capture data, and make sure that data is delivered at the point of care in a meaningful way. So where we are today, we have Cerner. You've all heard about Send, and that's actually being used in the clinical setting. One of the things that Oxfordshire has, which is unique, is a universal network. There was a question earlier today about how do we protect ourselves from attack. Well, actually, you know, one of the things we did do over that weekend of the attack is we had a really good boundary of defense, but also internally we made sure that actually none of the services got affected, and we had all the patches updated and all those things that you would have to do as a normal business to protect your interests. So, and what's interesting is when innovators don't continue to innovate on their platform, actually. So some of the devices that we have still want older platforms. Well, I need that moving on and developing, basically. We won the digital award, very nice. And we've got a lot of services which are out in the ward-based area. I think what's really interesting about this is, and I've been discussing over tea, you know, a lot of the EPRs are quite clunky, so they're actually prime for innovation right now. And there's a number of products which you'll see being talked about in the next few talks, which are about integrating with that infrastructure. And the main reason I find that's quite interesting is it's an area where we can actually do quite a lot of new things. And I think there's a need for a decent framework of innovation around this. So the reason I've got a Cerner product is I've got structure and I've got control and I've got a structured environment. But actually, I also need to enable innovation. And I think Nick might touch a little bit on the hill as well, because that's the sort of incubator model which we've got in place to try and bring new innovation into the place. Of course, at the end of the day, all of this is about patient care. So whatever we do, we've got to ensure that patient care and the patient pathway is seamless. So some of the things we're just about to do as part of the GDE program is start to connect records together in a more meaningful way. So Oxford has a summary care record at the moment, but actually we're trying to think of that as a much broader record integration between primary, community, and secondary care, and also the tertiary elements of that. Bringing that together so we can then map pathways digitally. I think what's fascinating about how this has been done in the States with the Affordable Care Act, and I know that's all been thrown up in the air a little bit now, and it's about to land, hopefully, in a more pleasant place than it was going to land, is actually the innovation that's occurred there has allowed digital, first of all, so get your services and products and your delivery of capturing of data in digital format, and then start to innovate on the care pathway, reinvent the pathways, think about how, you know, we currently send discharge summaries out. Well, if you had access to the record, you wouldn't need to do that. You just need a message to say there's a new activity that you need to look at on the record as a clinician. So we can actually find better ways of actually interacting and delivering care. So we've got a focus on these few things as strategic themes as trust, and particularly around the Go Digital area, which is the bit I'm responsible for. It also spills over to the rest, of course, because you can get, you know, better home care done. And I was interested in some of the technology solutions that were talked about earlier about looking at how you can prevent people coming through the door of an ED or an A&E department. So a lot of stuff about working with colleagues in domiciliary and home care, very important, within social care as well, because actually if you can do earlier interventions and monitor, then I'm a customer because I need to help with that. And then secondly, when people come through the referral pathway, so to the GP, into the secondary care, or even from secondary to tertiary care, then actually, again, I'm a customer for that because that's an area I need to make sure we've got the right innovation. And you'll hear about ORS, which does some of this already. Focus on excellence means doing things right first time, and if you've got the right information, you can do things right first time as a clinician. And that's really important. You've got more information available to you to make those decisions you need to make. Master planning is about physical estate, and if I can get rid of paper, I can reduce my physical estate. I can do a range of things. And again, that's why, for me, this pathway mapping and the digitization of it is so important. And then high quality costs less. And that's true. That really goes to the fundamental of getting it right first time, because actually then you don't have to repeat things over and over again. And that's really quite an important facet of what we're trying to do. Those are sort of broadly structured around two underpinning things: building capability in the organization, so the ability to take innovations and make them real. And there's a good example from the Hill, which is about factor rate management, and we're taking that one through because it was a very good idea. And that's a very simple one. If you can get the right number of doses into a patient over a period of time, you can reduce the costs substantially of the factor rate management. So instead of 100,000, you can get down to something like between 40 and 60,000. And that's just implementing a piece of innovative technology. Sustainable compliance. The NHS is probably one of the most regulated environments. In fact, I'm married to a regulator, so I've got to be really careful what I say here. But the reality is, the key facet is we have regulation on all fronts, whether it's the CQC, NICE, MHRA, all of those organizations actually come and regulate us. And we've got to be really on our game with what we call sustainable compliance. So that's what it means to us as a sort of strap line. This is what Go Digital is trying to do. And what I would like the world to look like, so this is me setting down the gauntlet to some degree, is I'd like the world to look like we've got an integrated record, that we can integrate technology, whether that's technology at home, technology that we provide, or technology that you can buy off the shelf, that we can monitor in a way which means we can try and head off people unnecessarily coming into the acute setting or other settings, and that there's a level of integration across the system, which means people's care does not fall through holes. And that, to me, is sort of the fundamental part of what we're trying to achieve with the care pathway and trying to pull it together. Pathway to innovation, this is a standard set of slides which you see. You have an idea, you invent, you innovate, and then you work through the process of solving the problem. So that's kind of the standard model which we operate under. As I say, the Hill is a good example of how we started that innovation cycle, to think about the creative idea, to think about how we invent something. And you've heard about Send, and that was invented in Oxford, and that's a really good example of invent. And then how you innovate, how you make it sustainable within the health system. And you heard Tim, we've got over 2.5, nearly 3,000, I suspect, devices of Send around the hospital taking observations now. Now, the future of that, of course, is where Tim was talking about, and how we take this potentially out of the hospital setting and further in terms of monitoring through care homes and other things. The other part about this is, of course, health technology assessment. This goes back to my previous job and what we used to do there in terms of research and making sure the ideas are actually sustainable and have scientific basis on it. We need to innovate, we need to make sure there's regulatory approval. So if you have a device, CE marking, all those processes have to be undertaken. I have a responsibility within the trust to make sure we've gone through those due processes before we introduce new devices. Coverage and reimbursement decisions. So bright idea, might save millions of pounds, but if the funding flows in the NHS don't work, then we have a problem. So we actually have to work with our commissioners to make sure we can actually innovate and pull that new tariff into the system, so then we can pay for the innovation. But that's just a standard process we have to do. And then, of course, adoption at scale. Tim and Lionel talked about Send, as I said earlier, but they had to go through the CE marking model. They had to do all the things that a regulatory compliance would require you to do. And I think it was an interesting debate about those passive devices versus those devices which need further regulation in the use, optimal use, and then disinvestment decisions. When cash is tight, disinvestment is difficult because actually you want to hold on to the device you've got for as long as possible and get more sustainable life out of it. So that cycle of getting that right for us is hugely important. So I thought I'd put this up because this is sort of a wordle of exciting things that patients want. So they want access to their record. They want it secured in secure systems. They want an integration care pathway, which means that when they come into a service, no matter where that service is, they're actually able to receive a personalized care in that way, so people know what they are. A very good friend of mine, Alex Markham, always says, well, I've given personalized care as a doctor all my life because I treat one patient. And he's absolutely right, because that's the way the health system works. But actually, we also need to do the other thing, which is population health and the ability to look at populations and intervene earlier with new sort of interventions. So that's a key area also. I guess that sort of covers a lot of ideas that need innovation and delivery, and that the mechanism for doing that. Now, we've got a rich environment within the Oxfordshire area, and particularly within the trust of, and you heard some of that with Jason's sort of view of the world. So we have the university that invents, we have the hospital that sandboxes and tests and looks at what's going on, and is this a device or system that would work? And then we've got, in this particular instance with Send, a sort of innovator that can commercialize, and then I have a different relationship because I become a customer at that point, and that's really important to me to delineate those two processes, because I need to have a reliable service at the other end of the development cycle here that I can pay for and operate and use. So that's kind of all the various bits that I wanted to really impart. The key thing is there's the hill, which Nick will talk about, where innovation, we're trying to incubate much faster and much quicker. Send, you've already heard about, because that's an innovation that's gone through. And then we've got some lifestyle monitoring as well that we've innovated with us in that same way. So these are just simple examples. So